It is often assumed that medical care inside wartime camps existed only as neglect or punishment, a blunt extension of violence rather than a structured system. In reality, camp medicine functioned as something quieter and, at times, more consequential, a bureaucratic mechanism through which bodies were measured, categorized, and either pushed forward or quietly reassigned. For prisoners, survival did not always hinge on resistance or rescue. Sometimes it depended on whether pain could be translated into language the system recognized. On the morning of March 1944, inside Ravensbrück concentration camp north of Berlin, that translation occurred for one imprisoned woman. The air carried the damp smell of thawing ground, and a thin mist softened the outlines of watchtowers and wire. Inside the administrative infirmary, a coal stove clicked as it cooled, while stacks of forms lay squared on a wooden desk, aligned with almost ceremonial care. Nothing about the room suggested change. And yet, a single medical report written there would alter the daily conditions of one female prisoner and quietly reveal how policy, paperwork, and the human body intersected inside the wartime camp system. This case does not concern defiance or rescue. It is not a story of escape, sabotage, or heroism in the conventional sense. It is the record of an examination, the language of medicine, and the way bureaucratic systems occasionally recalibrated themselves when confronted with physical facts they could not ignore. The subject was a female political prisoner, registered as a non-German detainee, whose treatment changed after a formal medical assessment contradicted routine camp assumptions. What follows is a reconstruction based on surviving medical logs, camp administrative correspondence, post-war testimony from medical staff, and comparative analysis drawn from similar cases across women's camps in Germany and occupied territories. It is a single case, but one that reflects a broader administrative structure. By 1944, the German camp system had expanded into a dense network of overlapping categories that blurred legal distinctions between concentration camps, labor camps, transit facilities, and prisoner-of-war sites. Female detainees occupied a particularly complex position within this system. Some were classified as political prisoners, others as forced laborers, and a smaller number as prisoners of war, particularly those associated with resistance movements or partisan units. Medical oversight within camps was not designed primarily to heal. Its purpose was administrative, to assess labor capacity, prevent outbreaks that could disrupt productivity, and determine whether a prisoner could continue working. Records suggest this approach was common practice across the camp system. Intake examinations, periodic health checks, and incident reports formed part of routine administration. In most cases, these documents confirmed existing classifications rather than challenging them. Occasionally, however, a report altered the system's own calculations. The woman at the center of this case entered Ravensbrück in late 1943. She was in her early 30s. Registered in intake records as a non-German political detainee transferred from a regional holding prison following interrogation. Her surviving file lists no name, only a prisoner number, nationality, and occupation prior to arrest. At intake, she was classified as arbeitsfähig, fit for labor. This designation placed her in a general outdoor work detail responsible for clearing debris, hauling materials, and performing maintenance tasks that required prolonged standing and lifting. Nothing in her initial examination distinguished her from the hundreds of women processed that month. Her weight was recorded as within an acceptable range. No acute injuries were noted. The camp physician initialed the form without comment. For several weeks, she worked under winter conditions, receiving standard rations and minimal rest. By early 1944, block supervisors began submitting reports noting repeated absences from roll call and visible physical decline. These reports were not expressions of concern. They were disciplinary notes, documenting reduced output rather than deteriorating health. Repeated inability to work could lead to punishment, reassignment to harsher labor, or further restriction. It was in response to these reports, rather than sympathy, that a second medical evaluation was ordered. The follow-up examination took place in the camp infirmary, a low building with barred windows and sparse equipment. Wartime photographs of similar infirmaries show narrow examination tables, enamel basins, and shelves lined with labeled bottles of disinfectants and basic analgesics. According to the surviving medical log, the examination focused on musculoskeletal complaints, chronic pain, and persistent weakness. The physician recorded swelling in the lower limbs, limited mobility, and signs of untreated injury exacerbated by prolonged exposure to cold. What distinguished this report was not the diagnosis itself, but the language used to frame it. The physician described the condition as a lasting physical limitation under strain, concluding that continued assignment to heavy outdoor labor would reduce productivity and increase the likelihood of collapse. The report did not argue for recovery or release. It argued for reassignment within the internal logic of camp efficiency. This distinction mattered. Within the administrative framework of the camp, prisoners who collapsed or required constant supervision represented inefficiency. Records from multiple camps indicate that medical reclassification often occurred not as a gesture of care, but when continued labor threatened to consume more resources than it produced. This case reflects how detention policies were applied pragmatically at certain administrative levels. Even within an ideologically brutal system, the medical report moved through a narrow chain of review. First examined by the infirmary supervisor, it was then forwarded to the camp labor office. There, an official annotated the margin with a brief note approving reassignment. No ceremony marked a decision. No announcement was made. Within 48 hours, the prisoner's work detail changed. She was transferred from outdoor labor to an indoor assignment involving sorting materials and basic clerical preparation. The work remained exhausting, but it was warmer, less physically punishing, and allowed for intermittent rest. Food rations remained unchanged. Living conditions did not improve. Surveillance and discipline continued as before. Yet the risk of physical collapse was reduced. In the language of camp administration, the intervention was considered successful. Cases like this were not common, but neither were they unique. Post-war examination of medical logs from women's camps indicates that reclassification occurred in a minority of instances, usually when a prisoner's physical condition became impossible to ignore within the system's own terms. Records suggest that such adjustments were more likely when visible deterioration threatened work continuity, provoked repeated disciplinary reports, or risked drawing attention during inspections. The system did not respond to suffering as such. It responded to disruption. It is important to note what did not occur following the reassignment. The prisoner was not transferred to a hospital outside the camp. She did not receive sustained medical treatment for her underlying condition. The reassignment did not signify recognition of rights or improvement in status. It represented a minimal recalculation, an effort to preserve labor capacity while reducing administrative friction. The role of camp medical staff in these decisions remains difficult to define with precision. The physician who authored the report cannot be identified from surviving documents. Post-war testimony from medical personnel across the camp system suggests a wide spectrum of behavior, ranging from strict compliance with orders to limited attempts at mitigation through bureaucratic language. In some instances, physicians framed medical findings in ways that aligned with administrative priorities, thereby creating narrow opportunities for reassignment or exemption. In others, examinations served only to reinforce existing classifications. This case does not allow us to assign motive. The report may have been written out of professional obligation, concern for efficiency, fear of accountability, or a constrained sense of ethical responsibility. What matters historically is not intention, but effect. A sentence written in clinical language, altered one prisoner's daily reality. Medical personnel occupied an ambiguous position within the camp hierarchy. They functioned simultaneously as caretakers and gatekeepers, constrained by policy yet capable of influencing outcomes through documentation. Their authority was limited, but it existed. Within a system governed by forms and classifications, language itself became a tool. The prisoner's surviving file continues for several months following the reassignment. Disciplinary notes decrease in frequency. No further medical evaluations are recorded. By late 1944, the record becomes fragmentary, reflecting the widespread destruction and abandonment of camp archives during the final phase of the war. Many individual trajectories disappear into this documentary silence. Post-war survivor accounts from the same indoor labor units describe such assignments as marginally survivable compared to outdoor details, particularly during the winter of 1944-45. Statistical analysis of camp mortality rates suggests that prisoners reassigned to lighter or indoor work had higher chances of survival during periods of extreme weather and resource scarcity. This does not constitute certainty for any one individual. It establishes probability. What this case ultimately reveals is not an exception to brutality, but the mechanics of its administration. The camp system was designed for control, yet it operated through procedures that required periodic adjustment. Policy did not function as a fixed script. It was applied, interpreted, and recalibrated by administrators responding to constraints of labor, health, and logistics. For prisoners, survival sometimes depended less on endurance alone than on whether their physical condition could be rendered legible to the system. Pain, in itself, held no administrative meaning. It had to be observed, recorded, categorized, and framed as a problem of efficiency. Only then could it alter outcomes. This single medical report demonstrates how policy operated at the intersection of ideology and pragmatism. The system did not soften, but it recalculated. In doing so, it altered one woman's daily conditions, not out of compassion, but out of administrative necessity. Cases like this help historians move beyond simplified narratives of cruelty or benevolence and toward an understanding of how captivity actually functioned. Examining similar records allows us to see how policy, paperwork, and human vulnerability intersected across the war, shaping survival in ways that were often quiet, procedural, and invisible.